entitled Advancing Best Practices to Expand Access to Self-Direction. Before we kick things off, I'm just going to run through a few quick housekeeping items. These should sound familiar if you've been coming to our conference sessions so far. First is your microphone has been automatically muted. Due to the volume of attendees, please remain muted so we can hear the presenters. You can submit your questions and comments at any time during the session by using the Q&A pod in the lower left-hand corner of the Adobe room. We do have time reserved at the end of the session for your questions, and all questions and comments will remain anonymous. This session is being recorded and it will be available afterwards on our website. And closed captions for the entire conference series is available courtesy of our premier sponsor, Avero. You can access the closed captions by clicking on the CC icon at the top of the Adobe room. So with all of that behind us, I'm really thrilled to welcome our first speaker in this session, who's Michelle Martin with UnitedHealthcare Community State. Michelle is the Senior Policy Director of Complex Care with the National Policy and Advocacy team. I am just delighted that we get to hear from Michelle and we get to talk about this exciting work together today. So Michelle, why don't you go ahead and get us started?
Thanks so much, Molly. Hi, everyone. Thanks so much for joining us today. It's really great to be here with all of you, and I'm really grateful to Molly and the team at Applied Self-Direction for asking if we could inviting us to do this session today. So as Molly mentioned, I'm the Senior Policy Director for Complex Care at UnitedHealthcare Community State. As part of my job, I get the very distinct privilege of staffing our National Advisory Board. I have a slide here that gives you a sense of the organizations that participate in our National Advisory Board. The NAB, as we like to call it, was started in 2012, just over a decade ago, and is made up of all manner of stakeholders. So members, providers, advocacy organizations, national and state trade associations, and other associations that are focused on the entire spectrum of people who utilize long-term services and supports that are funded through Medicaid. The board comes together to advise and make recommendations to United on things that we at United can do to engage members in a better way, and advance our clinical approaches, and really everything in between those. We have done all sorts of work. The board has some very distinct goals to, first and foremost, cultivate a consumer-centered culture, advance awareness and knowledge of the individuals who are served through Medicaid-funded long-term services and supports, identify emerging trends or policy issues that are impacting people who utilize LTSS, create a pathway that we can get to some policy advancements, which really gets us to why we are here today. So over the course of the last decade, the NAB has done a lot of different focus areas. We've had done a lot of different work focused in a variety of areas. You see here on the screen, in 2013, the work kicked off with addressing elder abuse. And I'm going to flash forward to the year that I joined UnitedHealthcare Community State, which was in 2021. I came to United in January of 2021. And, as luck would, truly a stroke of luck, the NAB, before I joined the company, the NAB had decided that in 2021, they wanted to focus on independent living and self-direction. So I had a really I was so excited to focus on this area. And so we did a lot of different interviews with our National Advisory Board members, and to really get what people wanted to really bring forth about independent living and self-direction. So I heard from our members, and I thought, I was talking with a lot of people through our membership, through our NAB membership. It was a lot of people who have a lot of experience into independent living and in self-direction. And so what happens if somebody doesn't know about these topics and they just do a Google search? And I'm sure it'll be no surprise to many of the folks who have joined us today that a Google search of independent living, the search results is mostly about assisted living facilities. And if someone just does a Google search of self-direction, it's kind of a hodgepodge of information. So I thought, let's start with what I would want to see if I got to decide what would be first in those Google searches, what I would want people to know about independent living and about self-direction as guided by our National Advisory Board members. So we did a bunch of work to really create 2 papers, one on independent living, one on self-direction. You can read them separately or together. And that really create a sort of grounding in what those 2 topics are, along with some challenges that exist, some from a policy standpoint to accessing independent living and self-direction, and some opportunities that we have to go further in both of those areas. And next, you're going to hear from one of our National Advisory Board members, Jennifer Kucera. And throughout the process of developing this work, Jen would constantly say, don't forget about dignity of risk. Don't forget that you really drive this point home, Michelle. Dignity of risk, having the right to choose, having the opportunity to speak my mind and say my piece and what I want for my life. And unfortunately, Jennifer was joined by another National Advisory Board member who was, they were really making sure that I really drove these points home. And the thing that really stood out to me in doing that work was Jennifer is so passionate about her ability to live independently, and the fact that she does not self-direct despite her best efforts. So Jennifer is in Ohio, and she's going to share more about her story of how and why and where. But she is not a person who self-directs, and that is because of some of the policy challenges that exist in Ohio. I'm paraphrasing because I don't want to steal Jen's thunder. But that really got me to think, where else are these things happening? What else is going on? How many Jennifers are out there? How many people want to self-direct but don't have access? And then I thought I needed to narrow the scope just a little bit, because I can't personally change the world, but I bet we could do something really great on our end at UnitedHealthcare. So I contacted our friends at Applied Self-Direction and said, what do you think about, just doing a deep dive with UnitedHealthcare, looking at all of our plans across the country that do have long-term service, do provide long-term services and supports, that do work with this population, and tell us what we're doing right, tell us what we're doing wrong. How do we make this better? How do we make it so that the Jennifers of the world have all of our support to self-direct if that's what they choose for their lives? And so after Jennifer talks about her experience, Molly's going to tell you what happened with that work. So we spent 2022 doing that deep dive, and it was incredible. Really a great experience working with Applied Self-Direction. And Molly will tell you the outcomes and the findings of all of the work that we did. And the fact that when Applied Self-Direction came back and said, here's what we found, at United, we said, let's keep going. We want to make sure that we are doing everything that we can to support every person who wants to self-direct, and really looking at this from a very holistic standpoint. So we are continuing to work with Applied Self-Direction through the National Advisory Board to keep going and keep digging on self-direction and how we can support self-direction, how we can influence policy in states that need some perhaps changed policies to enhance and improve their self-direction offerings. And I hope that we can come back here again in maybe a year, or maybe when the conference is back in person again, and tell you how this next year has gone. We're really excited to talk to you today about the work that we've done so far. It's been a really wonderful time of research and deep diving, and starting to put some of those recommendations that Applied Self-Direction gave to us into practice. And I hope that next year we're back to tell you about the outcomes of putting all of those ideas into play. So I'm going to turn it over to Jennifer to tell you a bit about her experience as a person who lives independently. And Jennifer is an incredible self-advocate and a person that I rely on a whole lot to keep me honest and on the right path. There are some photos here, and I'm sure Jen will talk about them, but I just want to start with this is artwork that Jen has created throughout her time during COVID, just to give you a sense of all the really cool stuff that she does in addition to being an incredible self-advocate. So I will turn it over to Jen, and I look forward to any questions that everybody has during the course of our conversation.
Thank you, Michelle, so much. Can you hear me okay? Just want to make sure of that.
Yep, we can hear you.
Okay. So, like Michelle said, I am a member of the NAB, and I've been a member of the NAB since 2019. When I turned 50, which was about 3 or 4 years ago, I decided that I was going to go into being an advocate almost as a full-time job. And that is exactly what I have done. The NAB kind of helped me to give me my voice. And even though today, as you know, I live in Ohio, I will be talking a lot about Ohio, but all of this information could be applied to any state that you live in. So currently, I'm actually working with several grassroots groups across the state to help fix self-direction in the state of Ohio, make it better, along with many other things that I do here along the advocacy route. I was actually born with a muscle wasting disease. It's a form of muscular dystrophy called spinal muscular atrophy. So I do have a developmental disability, but I've not let it stop me from doing anything I wanted to in my life. As Michelle said, I'm a huge proponent of independent living. I have lived in my own apartment now for the last 7.5 years, and I have absolutely never been happier. And I truly believe that with the right supports, anyone with a disability can live in their own home or an apartment, and that no one should have to live in an institution. I actually did live in an institution in a nursing home for 2 years following a vehicle accident that I got into. And after the 2 years of rehab, on getting better and finally having the courage, because until that point, I had not lived by myself. I'd always lived with family or friends. But I decided to take a chance and move into my own apartment. And I actually used a federal program called Money Follows the Person. And I always like to give that a plug because that program is so amazing. Without it, myself and many hundreds of others would not be able to get out of institutions without it. So if you do not have Money Follows the Person in your state, please try to advocate for that program. But like I mentioned, I've now lived in my own apartment for about 7.5 years now. When I moved out of the nursing home, I didn't know much about Medicaid, didn't know much about waivers or caregiver programs like the agency models, or some states have independent providers, or self-direction. And that's all what Ohio, now I know that's all that Ohio does offer. But when I was in the institution, the social worker really was not very helpful or educated either. They never offered me they only gave me one choice of a waiver, which was the MyCare Ohio waiver that I'm currently on. They never offered me a developmental disability waiver or even gave me that option. And they did not help me understand all the different caregiving services available. Well, had I known about self-direction, really that would have been very helpful, because when I got out, I decided to look around and I found neighbors and other people that were connected on the Ohio website for providers. But what I found was I had to call about 40 people, and that list that we have in the state of Ohio at the time was very outdated. Some people had actually passed away from that list. Some people yelled at me, "How did you get my information?" Others, the phone numbers were disconnected. But I did finally find a couple people that were able to assist me, but they were not independent providers. They did not have their licensure. So I, again, did not know about self-direction, even though I did have Medicaid. So I ended up paying out of pocket for my 2 assistants. And my mom's church, thank goodness, actually helped me with payment as well. Um, and I feel that, I mean, across the United States, there is a caregiver crisis right now. And I feel that with self-direction, it gives people another avenue to have caregivers in their homes. I do have for my own personal life, I have a split shift um, where people come in the morning and then again in the evening, and I'm alone in the afternoon to do my artwork, or you see my little puppy there on the screen who likes to ride with me as I transfer from my wheelchair to my bed and vice versa. But without those people, I would not be able to do anything. You would not hear me today. But there's a lot of people that don't want to become independent providers and get credentialed. They don't want to become STNAs or even the certified nursing assistants. So self-direction is perfect for those kinds of people. And I really wish I would have known about that program at the time. Currently, I am using an agency model only because the agency does not treat me like an agency. In an agency, I'm sure you're all aware, but they can send anybody at any time to your home. And I feel, since I do have a severe disability, that you can't just send anybody to my home. And you can't send different people every day. And my caregivers know that. Both of my caregivers have been with me the entire time I've lived in my apartment. And I know that I am truly lucky in that regard, because there are so many people nowadays going without the appropriate care. And I feel this is one avenue that can draw more people into the caregiving service. Again, with the severe disability, I believe that people should have 3 to 4 caregivers on their team. And again, the agency model really doesn't do the care justice, because there's no continuity. So self-direction or independent providers are definitely 2 solutions to that problem. In Ohio, self-direction is not an easy program. It should be easier to become a self-directed person than it is to become an independent provider. Independent providers have to go through a long application process, but the self-direction application process in Ohio is just as long and sometimes worse. It should be simpler than that. We have a organization called OOD, and they help, it's Ohioans Opportunities for Disabilities, and they help people with disabilities get jobs. And they have something called the PCA program, where you can hire your own caregiver. It's just like the self-direction program, but it is so simplified. It's so easy to get into that program, than with self-direction. In Ohio, there are 3 different waiver systems, as I call it: the Ohio Department of Medicaid, the Ohio Department of Aging, and the Developmental Disabilities Department. And they all have different waivers. And self-direction is, I don't think it's called self-direction in any of the programs. I could be wrong on the Ohio Department of Aging one, but they all go by different names. So that is a big confusion. People don't really understand the self-direction program. So more education, I feel, needs to be done to case managers, to social workers. A lot of times, I know, like in the nursing home, it's easier to sign somebody up for the agency model because it requires one phone call or one fax sent out to all the agencies in your area, whereas self-direction is more involved, but it could benefit quite a few people. I'm just checking my notes here. But when you're looking at self-direction within your own state, just make sure you know the process. I still haven't quite even found the application in my state. Like, I've searched and searched, and it's not a straightforward system like it should be. And hopefully Molly will be able to explain a little bit more about the process about self-direction within the United Healthcare system. Thank you so much. And when we get to the Q&A, please feel free to ask any question that you might have for me, please. Thank you.
Thank you so much, Jen. And this is Molly. I'm back. I really couldn't think of a better way to kick off talking about everything we learned in our environmental scan across all of the United Healthcare plans, because Jen, I think your insights really shine through and really line up with some of the themes that came out of our work. So really, really grateful that you could share your story. And at Applied Self-Direction, we were so honored to have the opportunity to do this work. And I'm excited to share with you today some of what we found. Before I start, I'll just note that United Healthcare also recently released a report that is essentially what I'm presenting on today. And so if you look in the resources pod, you can download that report if you want to check it out after today's call. So let me go ahead and get started. And first give you some context about our approach to the environmental scan. So we kind of took a two-pronged approach. First, we distributed a survey to all of the United Healthcare Community and State health plans across the country, asking some very targeted questions about self-direction. So some of the topics we addressed included, what are the opportunities and challenges for self-direction in your state? What supports exist for members who do self-direct? What does the enrollment process look like? We heard, Jen talking about some of the challenges that are in place in some states. Also looking at the quality of self-direction in those states. And we were really curious to learn about the impact of the pandemic and how self-direction was or wasn't responsive to those changes that we saw happen across the country. And then we conducted targeted follow-up interviews with a selection of health plans to really better understand the trends, the challenges, and opportunities that we heard about in the survey. And so that helped us drill down and really understand the scope of best practices and challenges and so forth. So let me share a little bit of what we learned from that process. First was that it was really interesting to see that engagement in self-direction really varied from state to state, anywhere from 50% of members eligible to self-direct were self-directing to 0.45% of eligible people self-directing. And that's of the overall long-term services and supports population. So this was really interesting to see. At Applied Self-Direction, we certainly knew there was variability in different states. I think it's also striking to just see that really the different policies and approaches and design choices around self-direction can really influence the level of engagement with self-direction. So really interesting to dig in and talk about, how do we get to such a wide spectrum of 0.45% engagement all the way up to 50% engagement? Looking specifically at enrollment of the health plans we talked to, we found that 60% self-direction enrollment had remained stable. This was something we were especially interested in following the pandemic, knowing that there was the potential for self-direction to grow. And then 40% of the plans did see enrollment increase during recent times. So that was very interesting. And then we spoke to health plan leaders. We wanted to get their feedback about what they saw as really the strengths of self-direction. What's the best part about this program and model, and what makes it work? So some of what people really pointed to, and I'm going to get into some of these in a little more detail, but major themes included, self-direction when it allows for the ability to set the rate of pay. That is tremendously impactful, particularly in the face of the workforce crisis. Also, multiple leaders pointed to the ability to provide better coverage in rural settings. Plans talked about really observing members be able to avoid institutionalization because of the quality of self-direction support. Having that flexible choice of worker really supported quality and satisfaction and good outcomes. along with having that greater control and autonomy that we all know comes with self-direction. A couple of plans were able to specifically point to some real data that showed there is a lower cost for self-direction compared to traditional care, and I'll dig into that a little bit. Also, a couple noted, just the ability to delegate nursing services, again, is an incredibly important flexibility. And certainly mitigating labor shortages is a feature of self-direction that I think many of you have been hearing us talk about throughout this conference is a big theme. And then the ability to accommodate diverse needs across different types of people from different backgrounds. So let me dive in a little bit to what we learned about some of these strengths. So speaking to that flexible choice of worker, these are just some direct quotes from health plan leaders as to what they said about what they were observing. So the biggest advantage is giving members the autonomy to choose who they want as their service providers and designing what they want the providers to do for them. Another leader said, members who self-direct have more consistent levels of satisfaction, primarily tied to the fact that they have chosen their provider and it is someone they know, such as a family member. And then finally, the biggest strength is the ability for members to hire their worker of choice, which is not available through another service delivery option. So we just were really hearing again and again that having this flexible choice of worker was a huge asset. Also looking at the capacity for self-direction to mitigate workforce shortages, we heard from leaders that 50% said the workforce crisis is really impacting both self-direction and traditional services similarly, meaning that we're really feeling the pain on kind of both types of program. But then 50% of leaders also said, the workforce crisis is less severe for self-direction, meaning that people who are self-directing are maybe a little more likely to find a worker or have less of a hard time getting set up with a worker. So this was a really interesting finding to see. And again, an opportunity to look across different state configurations and choices to see, okay, what's making this difference here? Speaking to that improved coverage in rural settings, I think one leader really put it well, saying individuals in rural areas may gain better access to care when self-directing, as it is often difficult for providers to support rural areas, though personal networks are typically strong in these areas, making self-direction a more suitable option. So again, rural settings working really well where people have these built-in networks in their community they can leverage through self-direction, engaging people who might not otherwise be, going the path of working for their local agency, but they do know their neighbor and they want to help that neighbor out. So that's something that multiple health plan leaders spoke to. And then I think it's really exciting to speak to what some of the health plans pointed out with regard to the lower cost of self-direction that they've been able to observe. So one health plan found, looking at a representative sample of older adults and adults with physical disabilities, they found that those folks self-directing used 20% less acute care, which obviously comes with lower costs, but also, I think we all agree that avoiding acute care is a huge success and something that I think we all want for our own health. And then another health plan really said that they encourage, when appropriate, the use of self-direction over agency services, as they find it's about half the cost. Meanwhile, it also comes with all these benefits that we've been talking about as well. Now, we also talked with health plans about some of the challenges they're experiencing with self-direction. We really wanted to understand that and look at what was contributing to those challenges and how we might be able to overcome some of those barriers and challenges. So some of the main themes, what we heard, I'm going to cover this and then I'm going to, again, dig into some of these a little more. One, which Jen really covered well at the top of the presentation, is just some states are really experiencing challenges with complex onboarding requirements that just make it very hard to get in the door and get started with self-direction. While we did hear from health plans that 50% said, hey, the workforce crisis isn't as bad for self-direction, it was still certainly a theme across our conversations. The challenge of worker scarcity right now, particularly for people who don't have friends or family or neighbors or a network to draw from for hiring. So for those folks that don't have pre-existing relationships, it's still a challenge to get out there and find staff. Additionally, we heard some comments about competition with traditional programs, specifically in some states and scenarios where the traditional agency, for whatever reason, due to different policies or structures, are able to offer higher pay or offer benefits that aren't available to workers through self-direction. So this was something we really wanted to understand better. Also, some of the health plans reported having some challenges working effectively with some FMS entities, so the financial management services partners in their state. I know some of you are joining us and work for FMS entities, so I will promise I'm going to dig into this a little more in a minute. And then insufficient information and assistance support. So information and assistance really refers to the kind of help that members who self-direct receive to learn how to be an employer, get resources around what does it take to hire someone, really just providing that coaching to help you to be successful in self-direction. I think any of us would need that, learning to be an employer for the first time in most cases. And so some states didn't see as much of that support as they would hope for. And then we did hear from some health plans that burdensome electronic visit verification requirements were presenting some serious challenges. I'm not going to get into that in big depth today on the EVV side, but some of you might have joined us last week to talk a little bit about some of those challenges. And hopefully you can check out that recording if you missed it. So speaking a little more to the complex onboarding requirements that we see, 60% of the health plans noted that members typically encounter longer wait times to access self-direction compared to traditional services. So, common reasons for this included having difficulty finding a worker and really, again, that time-intensive documentation requirements, particularly in many states. Health plan leaders were speaking about the length of time it can take to get criminal background checks back and approved. And 60% of health plans also observe that a major barrier to self-direction is just perception, that members believe that self-direction is too burdensome or time-consuming, that it's just more trouble than it's worth. So that is also a barrier to overcome. And then to speak a little bit to what the health plans noted in terms of challenges working with financial management services providers, I think it's really important to not acknowledge that every single health plan that we spoke to really commended their FMS partners for the important and essential work they do. So some of the themes of the recognition they gave was just really saying, our FMS partners are doing a wonderful job of fulfilling those essential responsibilities of managing hours and pay. And also spoke to, the real benefit of having weekly, biweekly, or monthly operations meetings for collaboration between UnitedHealthcare in a given state and the FMS in that state, or the multiple FMSs in that state. However, some of the partnership challenges they pointed to included, in states where there are multiple FMS entities, sometimes there's not consistency in the quality of service across the different FMS entities in that state. And that's led to some challenges for the health plans. Additionally, some of the health plan leaders noted that, the pandemic hasn't just impacted the direct care workforce, but also has created some staffing shortages at the FMS level. So really speaking to maybe some FMSs not having the capacity to do in-person enrollment or challenges like that was making it a little harder. And then financial management services entities, in some cases, having lower tech capacity created some challenges. So for example, health plans might be receiving data from the FMS in an Excel spreadsheet as opposed to a more sophisticated system, and seeing some lack of automation that would be really beneficial. And then interestingly, I think, some of the health plans spoke to really wishing for the FMS to do more on this information and assistance side, which, may or may not actually be the role of the FMS in a given state. So that's an important opportunity for education around who is doing what in the state and what's each party responsible for. So let me see. All right. So speaking a little more to the insufficient information and assistance, this was just really a theme across conversations around more support for the participant is really needed in many cases. Some of the health plans spoke to the burdensome paperwork, EVV requirements, lack of support, lack of guidance for paperwork and budgeting, really difficulty with getting started and understanding a budget, not having enough education around being an employer. And then I thought this quote was a really important one. This recognition from one of the health plan leaders was, members of the representatives often do not have the expertise or education to step into the role of employer, but if provided with additional support, we feel that these members could be successful in self-direction. So this was really interesting and pointed to, again, each state is structured very differently in terms of the choices they make about how information and assistance is provided. But these are some of the comments in health plans where there's some room for improvement in the way it's structured in the state. So I'm really excited to highlight some of the best practices that really stood out across the health plans, key attributes, strategies, actions that we saw seem to really be essential to supporting the success of self-direction, particularly in some of those health plans where we saw really high enrollment. These features were all in place. So one is really a commitment to the belief that any member can succeed in self-direction with appropriate support. This is essential. Really believing that it can work is half the battle. Additionally, health plans that spoke about having robust, consistent training for all their program administrators and case managers on the philosophy and operations of self-directed services that really go deep on this, saw some great outcomes. Also having consistently well-documented procedures to introduce the self-direction option to all eligible members. Really having processes in place that ensured every person who has the potential to join a self-direction program was hearing about it. And at least, getting briefed on, this is what self-direction is, it's available to you, this is what you need to do to get started. And then a major best practice was having intentional efforts to improve or enhance information and assistance resources that were available to self-directing members, really making sure that there were people available to help provide that essential coaching to know how to be a good employer. Some additional best practices across all of the UnitedHealthcare health plans. We also saw some of these great features. Cultivation of strong community partnerships. So between the health plan, both with FMS entities, as well as other community organizations that support the program. So meeting regularly with self-advocates, advocacy groups, Center for Independent Living, or AAAs or area agencies on aging were all, really features that were important to advancing self-direction. And then where state policy permits, empowering members to oversee the training of their workers and providing training resources as an option rather than a requirement was really essential. So, in many cases, there really is a need for some additional training support, but giving members that choice to decide what they're going to take advantage of was the key asset. And then really proactive engagement with self-directing members regularly to solicit feedback on their individual experience, as well as just getting overarching feedback on ways to improve the program was another significant best practice that we observed happening with UnitedHealthcare. Let me just get this slide. We also had the opportunity to really identify some important advocacy opportunities. So recognizing that each state, is structured a little differently and has some leeway and discretion about how they want to make different kinds of choices in developing their self-direction. We saw some themes where states might want to look to make some changes and where advocates might want to push to help support self-direction to grow. So one is because we were really hearing about those challenges with enrollment, there's a real opportunity for states to examine their enrollment processes and work to remove any obstacles to accessing self-directed services. We know there are states that have really efficient enrollment processes that are much simpler and enable access much better. So really looking and scrutinizing those processes in states where it's not going so well. Also, providing equitable access to healthcare benefits for workers in self-direction and agency workers. So I had mentioned earlier that, some states, there was really some existing inequity in terms of what workers could access, that maybe agency workers got certain benefits that self-direction workers didn't, and really trying to even the scales there. Also, increasing wage ranges in self-direction to be more competitive with agency-based wages as well. Again, some of you might be thinking, well, in my state, that's not a problem, but that's not the case in every state. Also, and this was kind of an insight coming out of the pandemic in particular, really allowing the provision of personal care during hospitalization, so long as services do not duplicate any that would be provided and billed for by the hospital. Some states had allowed for this during the pandemic, and some of the health plans spoke to how important and helpful this was. Another major advocacy opportunity is to really look to implementing budget authority through self-direction to allow members to raise their pay rates without necessarily increasing costs. So I had mentioned earlier that in health plans that do have budget authority, they really pointed to this as a big reason for the success of the model. And I think it's an important opportunity to point out that, again, self-direction can really vary based on the state you're in, based on the choices made in that program design. And there's actually a graphic on this slide that kind of shows the spectrum of flexibility that we might see in programs. So some programs, Jen was speaking to the program that she uses now that isn't self-directed, but people can share their feedback and preferences with the agency, and the agency is responsive to that, which is a wonderful model. If we get more into what self-direction really is, some programs allow for individuals to have that employer authority. So they have the member can hire, manage, and fire their own workers. And then some states offer really the most full-fledged self-direction, where members or individuals have employer and budget authority, which allows them to institute those pay rates, and in some cases also make flexible purchases of goods and services. So, I think in some states there's real opportunity to push for going further into the spectrum, offering more choice and control specifically through budget authority. And then some final advocacy opportunities. One is, and I know many of you are in states that are grappling with this decision right now, but see an opportunity. Many of the health plans were speaking to the importance of making any new flexibility during the pandemic permanent to allow family members to be paid caregivers. Many saw that as a real asset. Additionally, states could be looking to provide standardized guidance on self-direction implementation, including having, a strong, clear program manual and or formal regulations. We were certainly hearing about some states where this isn't as strong and would be really helpful, particularly to help all the different partners in the state work well together. Also, expanding the services that can be self-directed by amending the waiver application. Again, states vary here in terms of how many services can be self-directed. Also, hearkening back to some of the challenges that might exist in partnering with the FMS providers, much of this could be helped by increasing reimbursement rates to really better reflect the size and scope of the responsibilities of the FMS entity in self-direction. And then finally, reducing or simplifying requirements for EVV implementation within the requirements of federal law could really support self-direction. Again, states have a fair bit of discretion in terms of how they implement EVV and can definitely make choices that make it a little bit easier for self-direction. So that really covers the main findings from our work in this past year in this environmental scan. As Michelle had noted, we're thrilled that the National Advisory Board is continuing to partner with Applied Self-Direction to follow up on some of these recommendations and opportunities to just continue to expand access to self-direction. So just to give you a flavor of some of the things we're working on there, one is, really targeting efforts to expand self-direction in certain states where there are these opportunities to make some policy changes to strengthen self-direction. We are launching a community of practice for those UnitedHealthcare Community and State administrators as health plan leaders on self-direction to really come together as a national network. Also, working to start a national self-direction stakeholder advisory group that's really hearing from more people who self-direct to give their feedback to United Healthcare about, hey, this is what's working, here's where we can grow, and really develop that national voice of leadership. And also working on best practices to simplify enrollment processes for self-direction to really help, give states and stakeholders some guidance and ideas about ways to simplify enrollment, and also looking to support the training on self-direction for states and members to really advance. There's wonderful training already in place, but really working to continue to make it as strong as it can be. So with all that covered, we have plenty of time for questions. And before I start reading some of these questions, because I see some of them coming in, Jen and Michelle, feel free to chime in if you want to react to any of what I just covered from our findings, and then I'll get into some of these questions.
This is Jennifer. Excuse me, I'm sorry. This is Jennifer. I know one of the things that you talked about is the training of providers. And I just kind of want to say that when you have a significant disability, no matter if you have the agency model, the self-directed model, independent provider model, even if somebody has come from a nursing home where they have 12 years of experience working with nursing home participants, I still offer my own training because everybody at the end of the day is a little different and likes to be handled a little different and has different wants and needs. So really, if there's anybody on here that does receive services, do not be afraid to educate your providers because they don't know if you don't tell them. So, and even if you are a case manager or whatever your make sure that the participant does know that they are allowed to help train their provider. Because again, everybody is a little bit different. So I appreciate that comment that you made, Molly. Thank you.
Yeah, thank you, Jen. Well, let me go ahead and dive into these questions because I see we've had an active audience, which is always exciting. I'll kick us off with, the key findings and best practices of the environmental scan is extremely interesting. Is the full report that includes the data publicly available? So the report is available. We've linked to it in the resources pod. So actually, if you're looking at your screen, there is a link to the report. And you can download it and take a look. And in terms of the full data, I don't think that that's publicly available, but I think many of the key findings and takeaways are included. And I know there are many interesting opportunities to provide additional data on some of these points that may not be in the report. So if there's certain, for instance, looking at how self-direction can cost less than traditional services, there's a lot of research out there that corroborates this. And we'll be glad to share those types of findings with people if you're looking for some of that data. And Michelle and Jen, I don't know if you'd add anything about the report. I'll just look at the next question here. All right. In the state of Maryland, we have support brokers to help with the employer role. Is this offered in other states? It's a really good question. The support broker model is available in other states, but not all states. Some states take different approaches to how they offer information and assistance. So it's not unusual that there might be situations where it's actually a case manager who is also providing information and assistance support. So the same person who's helping to make that connection for enrollment might also be supporting the person to have self-directed services. We saw some interesting models where there might be similar to a support broker role, but going by different titles. There's many, many different ways that states structure offering information and assistance, but I do think the support broker function, and this is someone who's really their whole job and focus is on supporting people to effectively self-direct and to be that coach, is a wonderful model that I think is definitely associated with some of these best outcomes for self-direction. And Jen and Michelle, again, don't let me hog all the answers. So feel free to share your thoughts too on the support broker model. Okay, so here's a question for Jen. What advice do you have for advocates that are looking to support self-direction?
I would say start by knowing the system. So looking at the different, if you have waivers within your state and knowing where self-direction options are available, even, learning the vernacular because self-direction is called different things in different places. Not even in my state, it's not even called the same thing throughout all the different programs that are available. And even, doing Google searches to find out how much information is available in your state about self-direction is really a good place to start. And then talking even to your folks at your Medicaid department to find out, how behind they are in self-direction and offering that to people. And then even within the managed care organizations within your state to talk to those folks as well. So there are a lot of different avenues that you can take to advocate in your state, but the first is about educating yourself about what is already available.
Great. Another question for you, Jen. Are you a member of UnitedHealthcare? And do you feel like managed care hinders your access to self-direction in Ohio?
Yes, in full disclosure, I am a member of UnitedHealthcare. I have been for quite a while now. Within the UnitedHealthcare system, I am glad that they did this deep dive into self-direction because the states, could be better at what they are offering, including my own. Um, do I feel that managed care companies can hinder this? Yes, I do, because their case managers need to be really educated in this program and to be able to offer it to their consumers. I mean, when I started, I knew nothing about the caregiving system. I didn't know where caregivers were going to come from. I didn't even know I had options. So education, and I was an educator, so I have education at the heart of me, but education is a great place to start. So managed care companies, if you're out there, besides United and including United, please look at your own system and see where you can make your managed care company better and really learn about self-direction so that you can help your members and teach them that this program is available.
Really well said, Jen. I read the next question here. How many UnitedHealthcare state health plans are included in the report data? So this was from, I believe it was 10 health plans that participated in this process. And I also, there was a comment, this was for Michelle. Love the comment, Michelle, about keeping dignity of risk in the forefront. Thank you. And I agree. A wonderful comment.
I'm just going to say thanks to Jen because she was certain to make sure that we kept that at the forefront of our planning throughout. And Jen is somebody who makes sure that she is continually honored. And I just want, for one quick second, when Jen was talking about the ability to, for plans to get educated, we have, we are very fortunate to have Jennifer and the voices of others who are willing to share their experience, share their story, tell us what it's been like for them so that we can continually improve our model. We don't look at this and say, we know exactly what is best and we're going to do it this way. It's here's our model. How can we continue to improve it and make it better for the people who utilize our model? And, I'm endlessly grateful to Jennifer because she's always willing to share. And we have, many members who are willing to share their experience, employees with disabilities who are willing to share their experience of being within the LTSS system. So in my mind, it's always been very important that we can come at it with, we can come to the table with our best ideas, but our best ideas can only be really brought as best practices if they're informed by people with lived experience. And that we hear things like honoring dignity of risk. So thank you for that comment. And again, thanks to Jen for always being willing to be the voice and let us hear from her. And I wish I could thank all of our members, but they're not all on the line right now. But there's been a lot of people who have who have guided our work. And I want to note that it's been people, we have taken guidance from consumers, from family members of consumers who have been very deeply involved, from caregivers, from paid caregivers, from unpaid caregivers, really wanting to hear what the experience has been throughout the continuum of care. And it's been invaluable for us. So we keep getting more information and keep trying to do better based on the information that we receive, and keep educating ourselves.
Very well said. Thanks, Michelle. Just getting to some of these other questions. It looks like we're short on time, so we probably won't get to all of the questions, but I'll get to as many as we can. In Maryland, the Developmental Disabilities Administration allows the individual to offer medical benefits. We can put funding in the budget to cover this. Do they offer this in other states? This comment and question is a nice segue to say, certainly not all states, but some states. And I think your comment really points to the importance of budget authority, and why I think that's one of the great recommendations coming out of this report is for states to look at that option. Because again, that is a choice that members or participants can make, is to, include that in their budget and their rate of pay. And that can be a really important asset in the workforce crisis. And Jen and Michelle, feel free to add on to that, but that was my reaction to that one. All right. And then a question, how can you become part of the stakeholder advisory group? So this is specifically going to be through UnitedHealthcare. So if you are a UnitedHealthcare member that is self-directing or wants to self-direct, I would encourage you to reach out to any of us that are part of this group, because that would be the way to get involved. And Michelle, I don't know if you'd add anything to that, but we're just looking at getting this started.
Yeah, we're on the early phases of getting this out, getting this stood up. But if we have anybody on the line that is a United member, please do reach out. We are really interested in hearing from a very broad group of individuals, and I'm really eager to get more voices, more self-direction voices to the table with us.
Great. Okay, I think we have time for this one last quick question. Can you become a broker in a different state that you don't live in? And I can just answer this to say it really depends on the policies and rules of any given state. So it's certainly something worth looking into. It's something that states were certainly a little bit more flexible with during the public health emergency. So there's certainly some potential opportunity. I don't know offhand how ubiquitous that option is. But I do know many states don't allow for this, so it's something to look into. With all that said, thank you everyone for joining today. Huge thank you to Michelle and Jen for being such tremendous partners in our shared mission to support self-direction and all the work you're doing. And thank you everybody today for being part of this conversation. It's been wonderful. And as Michelle said, we look forward to reporting back hopefully next year on what more we've learned. Thanks everybody.